Hello, I'm Chris Perry. I'm the owner and founder of Perry Prosthetics and one of the several prosthetists that we have here. I want to thank you for joining us for this video segment today. The purpose of this segment is to introduce you as a new amputee to the journey ahead of you for prosthetic care. We will talk about the amputation and some of the things that you will experience at the hospital and then at discharge and after you return to home. So if you are not in the market area for Perry Prosthetics, you're outside of our service area and seeing this video, it's got a lot of great information. The things that you experience from your surgeon and your prosthetist team may be different than what I'm talking about here, as everybody does things a little bit different. Also, this is a presentation that I have done for years in person with new amputees, and if you are within our market area, we will be seeing you for an in-person consult. The nice thing about the in-person evaluations are we can get some history on you specifically and have a much better idea of the process that you're going to be taking. The difference between what I talk about there and this video is very general because I don't know what level of amputation you've had and what your past history looked like. So the information you'll get will be a little more generalized, but it's very pertinent to the pathway in which you will follow. Part of the reason that I do the education videos and these consultations, because they are at no cost, they're a no fee benefit to you, is because of my commitment personally to the patient and patient education. I've been an amputee since the early 1980s. And when I went through the process, I remember very well asking questions and nobody really having answers. There was no prosthetic visits. And there's many times in many places, prosthetists still don't visit. Some places do, some places don't. The quality of that visit could be 5 minutes. Here's who I am, and here's my card. Myself and my team, when they visit your first consultation, they set aside an hour and a half to spend with you and your family and discuss, getting to know you and learn about you, and then discuss what's ahead of you. So as a commitment from what I learned at the age of 16, not having information and knowing how difficult that was, until a friend of a friend of a friend came in that was an amputee and just shared his story. Didn't tell me what he thought I was going to be able to. He just shared with me his journey, and that was enough to give me a glimpse into what was next, and that has inspired me. It's really been the basis of everything we do at Perry Prosthetics as far as patient care and education and making sure that your prosthetic care is our biggest priority. Before moving into the journey that you're about to take within rehabilitation, your prosthetic rehabilitation, I would like to discuss the emotional side of limb loss. So, as I just told you, I lost my limb in the early 80s. I was 16 years old. I struggled with the emotional healing of limb loss longer than I probably needed to for a couple reasons. But I do remember very well, I was a small town farm boy laying in bed, and some of this will probably ring true to many of you, but we're laying in bed. We've just gone through whatever it is that we've gone to that led to limb loss, and we were experiencing a lot of different things, but one of them, a very strong and powerful one, is that you feel like you're a burden on the people around you, the people, your family, your loved ones. And that's a hard feeling to shake. And I think it's important that you understand that, one, this is temporary. This is a temporary part of where you're going. And you're going to get back to doing the types of things you were doing before. Two, you have to see yourself through their glasses. You have to know if this was one of your loved ones in that bed, they would certainly not be a burden on you. Matter of fact, you'd probably be the first person to step up and be there and say, what do you need? And throughout the first several months of your journey, as you heal up, as you get fit with the prosthesis, as you're learning how to use the prosthesis, and then as you start implementing it through your everyday activities, during that journey, you have to feel comfortable letting those people help you, because their help is going to allow you to get there safer and quicker. And believe me, you will get a to-do list back at the end. You're not getting off with any free passes. So it's important to discuss how you're feeling, particularly right in the beginning, but at any time throughout the process with family members, with somebody from church, clergy, an emotional support team. Ask your physician for a consultation to a psychologist or a counselor. Talk to your clinician when you meet one of us and ask them. We can sometimes arrange peer support as well and have somebody come in that's been through the process, that they'll just come in and share their journey with you, and then you can ask them all the tough questions. And emotional wellness is one of them. So it is a very important step in the healing and rehabilitation process. So having said that, I want to start with the two biggest questions that I hear. The two biggest questions are, what am I going to be able to do, and how soon am I going to be able to do it? So everybody goes through this process and have their own unique circumstances and outcomes. It's unique to each individual. Whether you're an above the knee amputee, a below the knee amputee, upper extremity, partial foot, all of the experiences are different. But generally speaking, most people return to the same type of activities they were doing most recent before the amputation, or whatever the cause of amputation was. If you were walking with a walker for the last 5 years and then ended up with a wound, and then because of that was in a wheelchair, and now you have an amputation, and what are you going to get back to doing? Our goal is to get you back to walking with a walker, because that's the way where you were at before. And then once we get you there, we will work at getting you back to walking with lesser assistive device, whether it's a cane or no assistive device. But in the end, we want you to experience the best outcomes you can in the safest manner. Having said that, if you were running 5Ks 3 weeks ago and you were involved in trauma and you want to get back to running 5Ks, that is our goal. So what possible varies greatly depending on what you were doing most recently before the amputation. As far as when you're going to be able to do that, generally speaking, after the amputation, providing that everything goes smoothly, there's no setbacks, we're usually getting involved with the prosthetic fitting process right around week 3, 4, possibly 5, depending on the surgeon and when they like to take out the sutures or staples. Most are using sutures, and when they would like us to begin with compression therapy. Talk about the shrinker socks real quick, just so you have an idea what the difference is in them. The light compression is going to look like this. It's just a cottonette that comes in a tube format. We have different sizes available. We'll come in and measure your limb, and we will put this over your limb. We use a donning device for the first layer of it, so that it's more comfortable on you and it's not dragging against your skin or the bandage that you have over your sutures. So it goes on pretty easy. And then it has this plastic ring in the middle that we can move that. But then we take the second layer and refract it back over the first layer. So it's light compression, but it's doubled up, and that's how it will be on your limb. And it's easy to take off and put on, and it comes in a variety of sizes. Now, we will not use this type for somebody that's an above knee amputee, because it's very difficult to get it to stay up, and we don't want it to shrink down and bunch up. So we'll use a bigger shrinker sock. This looks little, but they stretch quite a bit. This is a shrinker sock, so it has more compression than the light compression, But in the case of being a new amputee and being early and after amputation, we use the same device, but we oversize it so that it's, if we size it according to your limb and the recommendations from the compression garment company, it would be too much compression. So we step it up to just a size bigger so that it stays up good and it's easy for you to put on and off, especially using that donning tube that you'll learn about, and it doesn't provide too much compression. Once you're ready for the higher compression, we just resize it and get you into the higher compression. As you move forward, whether you're above the knee, below the knee, or even a different level of amputation, and you're ready for full compression, we put you in a shrinker sock, and it's designed to be about 20 to 30 millimeters of compression, which is pretty snug, does a great job of getting rid of excess fluids, helps with the healing. A lot of times it helps with the phantom pains and sensations you may be having. So we get you in the shrinker sock, whether you're still in the hospital or at home, the sutures have been removed, or maybe just before that. You wear the shrinker, we follow up with you. If you shrink quite a bit, we'll get you into the next size smaller. But once we see you've stabilized a little bit, we start the actual prosthetic fitting process. That's usually with a scan or a hand cast. There's a couple different ways to get there, but they all produce a working model that we can use as a model or that represents your limb, and then we fabricate a clear plastic test socket on that. So the consult in the hospital is one appointment. The evaluation appointment in our office to determine what's the best appropriate is a second appointment. The scanning, depending on if there's going to be a gap in time or not for any reason, we can do at that evaluation appointment, that second appointment. But if not, we have you come back for a scanning appointment. And then the fourth appointment would be having you stand in a test socket. Most of the time, below the knee amputees, we're getting away with 1 to 2 test sockets, depending on the complexity of your limb, the quality of the amputation, and specifically the goals in which you have, your capabilities of what you can do with that prosthesis will determine whether we feel the fit is appropriate for finishing up. And then the appointment right after that would be the final delivery of the leg, of the prosthetic leg, so that you can begin physical therapy, which we also help get set up for you because we have an idea where you're at in space and the fitting space, the timeline, and we preemptively get things ready so that there's no gap in waiting for a physical therapy appointment to happen. For an above knee amputee, we're probably about 1 test socket more. So that just extends that time frame about a week, because we're right about a week for each appointment once we start the fitting process. Depending on the complications with payer source to approve everything, we may, and a lot of times we do, get a PM&R physician involved. Their job is to look at you as the big picture and help put together what your needs are for rehabilitation. And so their notes reflect that. We work together as a team with different PM&R groups in the area, and their contribution as far as documentation is incredible and many times crucial to get things approved. So the setbacks could be a limb that's taking longer to heal, the setback of the addition of the compression therapy if it wasn't done, kind of overlapping the sutures coming out, and then also falls or injuries. If you're a new amputee, you don't want to fall. Nobody wants to fall, particularly if you're a new amputee. One of the things that can set back the entire fitting process and even the characteristics of your limb is if you fall and break open an incision. Most of the time, if you break open an incision, they can't suture it back shut because of bacteria. They have to let it heal shut like a wound. Healing a wound takes time, which delays the entire fitting process. It also may leave scarring that becomes an obstacle in the prosthetic fitting process. A lot of times we can fit around that. Sometimes it's more difficult than other times. I'm giving this talk about falls and how to avoid them, mostly because when I was a new amputee, I was 16, I went home. The first week I was home, I
I fell, landed on the end of my limb, broke it open slightly, not bad, and went back to hospital for a week. The pain from that fall is something that I still remember. So we don't want you to fall. My tips and tricks to not falling are pretty simple. One, take your time. You're going to get back to doing those things. Don't throw caution to the wind when it comes to maneuvering, getting out of bed, using the bathroom, moving across the room. If there's something on the floor, have somebody move it, or you move it. Don't try to negotiate it. Don't try to go over it. Don't feel so confident that you can get around it. Even if you could, still take the time to make the area safe. The areas to take your time are bathroom activities. That's where we see people fall the most. Getting up and being in a hurry to get to the bathroom. If you're not going to make it to the bathroom while being cautious, it's way easier to clean up a mess than it is to delay yourself for a month or a month and a half and go through all the pain of the fall. If you have issues with the frequency of going to the bathroom, try using the clock and giving yourself times or set intervals where you're going to just get up and go, because you know you're going to need to. That way it doesn't become an urgent situation. The other area that we see is people waking up groggy or tired and swinging up over the edge of the bed and standing up and walking away, forgetting that they don't have their limb at whatever level, and falling. So it's always important, if you're in a hospital bed, that the rails are up when you're sleeping. If you're not in a hospital bed, put whatever, if you're using a chair or a walker, put it right next to the bed on the side you get up, so that it's right in front of you, so that when you do get up and you see, hey, that thing's in my way, it'll jog your memories of why it's there, and then you'll remember not to get up and walk away. One thing I learned a long time ago from a gentleman that was a ski instructor for amputee skiing was, if you are standing on your leg, whichever leg is not been amputated, and you go to fall, you're automatically going to put the opposite leg out to catch you. It's not such a good idea to do that now that it's gone, because you'll fall on the end of it. So and that's a reflex. That's something, because we've been, our whole life we've had the limb. When we fall, we do that. To break that reflex, you need to make eye contact with your limb. So if you're in a situation where you're being safe and you still ended up where you feel like you're going to fall, you're actually going down, I want you to take time to look down at your limb. Your hands will do what they need to do. They've been doing it your whole life. But take down time to look at your limb, and you will automatically bring it up and draw it out of the way. And your body will take over, your instincts will take over and protect that area, as long as you look at it and remind yourself it needs protection. So just looking at it will save you from landing on the end of it 9 times out of 10. And I don't know how many times I've heard over the years people come back and say, wow, that worked. I fell and I landed kind of on my butt cheek and my hand, and I did not hit my limb. So that's very important.
The early post-op phases, if you're in the hospital right now watching this, or maybe you're watching this beforehand, directly after surgery, the protocols are very dependent on the surgeon himself or herself, and whether or not they partner with the prosthetist and what they've come up with. Our surgeons, most of them like to get you into light compression, whether you're above the knee or below the knee, and then some kind of protective device, particularly for the below the knee amputees, which we use what's called a rook. And they like to get us involved with this consultation soon, usually within the first 2 days after the amputation. And the reason I'm doing this video is if for some reason it falls in a holiday or weekend, or the schedule makes it more difficult, we like to be able to be there, and we make that a priority. But this video is an option to get this information. If they order a post-operative device, we'll be in. We'll deliver the post-operative device, the compression, if they order compression, and doing this consultation very soon. If it's outside of our service area, if you're watching this from, Oklahoma or wherever you might be, or somewhere else in Ohio, then you can kind of use this and discuss these things with your prosthetist or your surgeon. This is good information I feel anybody should have right away, so that it shines a little light on the unknown and gives you a little comfort of knowing what's next instead of waiting to see what's going to happen. So as far as discharging from the hospital, while you're in the hospital, you should be getting some PT and OT. So physical therapy comes in, they work on range of motion and strengthening that will help prepare you for mobility without a prosthesis. So if you're using a walker, it's mobility with a walker, crutches, a wheelchair. If you need a slide board, it really depends on each individual and where they're at, but that's part of the physical therapy while you're in the hospital. OT comes in and helps you with daily activity functions such as self-care and being able to get dressed, do your hygiene in the morning or in the evening before bed, cooking and clean. Those are the types of things that you're going to get right while you're in the hospital. I would encourage your physical therapist to give you some things that you can take home to work on in your own time to help with the range of motion, which means how much movement you have and as far as angle in the joint, and strengthening, because really that's your golden time to get prepared for the prosthetic fitting. And the better prepared you are, the quicker the process goes for you. So whether you discharge to home or you're discharged to a skilled nursing facility or an acute rehab facility is up to the hospital discharge team and yourself. You're part of that, so you can always give your input. They will make that determination based on your abilities. So they'll just test your abilities and make sure that you are able to have safe, comfortable mobility to get, if you're going home, you got to be able to show that if you live in an apartment, you're on the second floor, they need to see that you can go up those steps safely and using an assistive device and be able to get in and out of the apartment. They want to know if you have a support system. So there are other options, or a skilled nursing facility that you would go to while you're going through the healing process. And then we work with people that are in skilled nursing to help them get their prosthetic care. And then they also have physical therapy and occupational at skilled nursing facilities. So it's advantageous to go to a facility like that if you don't have care in your home, or the obstacles at your home are greater than you can safely negotiate. I'm going to talk about acute rehab now. So there's some acute rehabs that are in hospital settings, and there are some that kind of resemble like a skilled nursing or a nursing facility, except for they specialize with rehab associated with different disease processes or pathologies that require advanced therapy, and amputation is one of those. If you end up in an acute rehab setting, that's your opportunity to work more than one, like two times a day with a physical therapist and at least once a day with an OT to get a high volume, condensed, very effective physical therapy program to prepare you for home and your prosthetic use. And I feel that that is often the best case scenario if you qualify for that avenue. So I know a lot of people are like, I just want to go home. Really think about how important those first stages of rehab are to the very end goal and the outcomes you get with prosthetics. Physical therapy is important that you learn and even maybe get given some exercise programs that you can do at home, whether you have the prosthesis yet or not, so that you can continue to do these on your own and keep yourself strong, keep yourself flexible and mobile, and continue to do better with the prosthetic care as you re-engage in all the activities that you want to get back to doing. To talk a little bit more about the prosthetic overview, our team at Perry Prosthetics they're going to be with you from the beginning. We have a patient care liaison that will talk to you within the first week of meeting one of the prosthetists for your consultation, and he is there to check on your progress, make sure that he knows when your follow-up appointments are with therapy, where you're at with regards to your location, if you move from one facility to another, and to be a resource for you. If you are looking for more information, he will get you in touch with the right prosthetist or get you some of the resources that are available. And largely, part of his goals are to make sure that you don't fall between the cracks anywhere and your care is delayed. I mean, make sure things keep moving. So you'll hear from that person. His name is Theron. And then if for some reason you have something come up that's a change in care or location, you can always reach out to the office and ask for Theron, and they will get him your information or a message, and he will get back with you. So the prosthetic process is, once we see you for your consultation, you have that follow-up system. We get you into the office at that time. We do a complete evaluation. We start devising, if we haven't already kind of put together the treatment plan as far as prosthetic type. And when we say prosthetic type, we're talking about the fitting style, the socket design, the suspension type, the type of components, whether it's a knee or a knee and a foot or just a foot, that will work best for you and your desired outcomes. And part of that process is we actually do a few different evaluation tests. Some of them are just survey-based. In the beginning, it's only one of those. And then we do a couple performance-based, where we ask you to do different activities, and we do them with you. They're designed for without a prosthesis, and that helps us get a better idea of your potential lies as far as function and what we should be looking at for the device build, the type of device. That also helps greatly when it comes to getting justification with the insurance or payer sources, because that can be another delay. We're very good at being an advocate for you, but we need to get the right information together to do that. And then sometimes it goes beyond that. Sometimes we need to get the patient involved as well. We will certainly let you know if that's the case with your payer source, and also help you understand what that means. Most of the time we can do it with the staff we have. We have a great staff, very good at getting the things that you need in an appropriate amount of time. So sometimes we'll have you get scheduled with a PM&R physician, which is a physical medicine and rehabilitation physician. Their specialty is looking at you as a whole and making sure you have everything that's available to you for a successful rehabilitation with the best outcomes possible. That appointment, we try to fit in to the process so that it doesn't delay the actual fitting part of the prosthetic fitting process, and not delay the point in which you receive the prosthesis and begin physical therapy. Sometimes it does, but most of the time we're very good at layering that in. The PM&R physician provides documentation that is designed around you and your needs for rehabilitation, and is critical for getting authorization with payer sources. So the next thing I want to move into is pain. There's three types of pain, really. There's limb pain, phantom pain, and phantom sensation. They're all classified under pain. Limb pain is what you're going to experience from the surgery itself. Anytime you do anything to your limb, whether you bump it, hit it, or fall, or the surgery, or if you end up somewhere and you're working with prosthetics and that prosthetic causes you pain, that's limb pain. It's in the limb that's residual. It's the limb that's still present, and is usually a physical cause. There are some times where there's an intrinsic cause, where there's a nerve that's sending signals because it's inflamed or swollen. We can identify these things, and there's different things that we can do to help eliminate that. Sometimes that would require a surgical follow-up. Other times it does not. It really depends on what you consider tolerable and not tolerable, and whether or not we can fit around it, or if it needs a surgeon to look at it. You won't have those types of pains early on. Those are something that may show up later. Most of the time do not. Phantom pain is actually a real pain. Phantom doesn't mean it's not real. It means that it's in the part of your limb that's absent. And it's a painful sensation. So a phantom pain would be a burning sensation, or a twisting sensation, or sharp stabbing, or quick electrical jolts, or anything that's unnatural that's in the limb that's absent is a phantom pain. There are ways to work around them as well. A lot of times with people experience phantom pains, they're pretty much right after the amputation and subside fairly quickly. The shrinker sock compression actually helps with that. So that's something that we want to get to as soon as we can, that will not delay the healing. So that's why we start with light and go to heavy, because you need some of that swelling for healing. Phantom sensation is also in the limb that's absent, and they can be painful, but they're not unnatural. So it's a type of pain that you may have or could experience if the limb was there, such as an itch, or maybe you get like a cramp in your toe. So it could be a pain if you feel like you got a cramp in the toe or ball of your foot. That's more painful. It's easier to get rid of. It's also not as common, but it's just the sense of feeling that you have in the limb that's absent, that's not necessarily painful, but it's certainly not unnatural. I had one for several years where I felt like I was standing in a puddle of water and my toes were wet. So that was a interesting one, and I kind of miss that one because I no longer have it. The biggest thing about phantom pain and phantom sensations is that you really need to make sure that you let us know that you're having them, so that we can kind of look a little closer and see if it's something that we can do something about. We did talk about the compression and the limb shaping with the shrinker socks, but one of the things I didn't discuss at that time is also positioning your limb and desensitizing. And this won't happen immediately. Well, the positioning is important all the time. You don't want to sit, if your amputation is below the knee, you don't want to sit with, say, a pillow behind your knee and having your limb bent over the pillow. Because what will happen is, because you're sitting, you're not up walking, you're not getting the exercise to keep it moving and stretching, is that all the flexor muscles and tendons will tighten up, and all the others will be a little stretched. And then when it's time to get up and start using your limb, you'll have trouble straightening your knee. And that sets back how well you can utilize the prosthesis. We can still fit it. It changes some of what we need to do to fit it. It may make it harder to make it comfortable, because now your knee's bent and we're putting all the weight on the front portion of your limb instead of evenly distributing the weight. So it's best that you just keep it in a good position, which would be maybe with a pillow, maybe out further, so the pillow is not under the bend of the knee, but under the end of your residual limb, so that holds your knee more straight. So being straight for long periods of time is not nearly as big of a problem as being bent. Same thing for above knee amputees. So they actually have, more often than not, have to work at putting themselves in a position of stretching, because when you're sitting or laying in a bed, you're pretty much flexed. Unless you're laying flat or laying on your stomach and your leg is pushed back into extension, it's difficult to not get a contracture. For above knee amputees, it's pretty common that they come to us and they have more of a flexion contracture, which is where the tendons and the muscles are tighter on the front side, causing it to not extend back. It's typically more of an issue with them. Some of the things you can do, first of all, make sure for both of these, you ask your therapist, hey, what should I be doing to make sure that I keep good range of motion and I don't get a contracture? And what are some things I can do at home, what I can do on my own? What are some things I can do right here in this bed? Find out and get that information, and make sure that you're also taught and demonstrate how to do it, so that it's not just them telling you, It's them showing you and you actually doing it. Rolling over on your stomach as an above knee amputee, depending on what you've got going on and where you're at, can be difficult, but it's an excellent way to get your legs straightened out. And you want to be able to do that with your hip bones touching the bed. A firmer surface is better. So if you go down to a therapy gym, they may do something like that on a firmer surface. They may just do it manually, have you laying on a firm surface and manually kind of take your limb and push it down and help you stretch it out. In bed, sometimes they'll come in and have you just take that amputated side and hang it over the edge of the bed and kind of push back or push it back down below the bed, level of the bed, which also stretches it. There's many different ways to do it. The biggest takeaway from this is that you find out what those ways are and begin using them. As you get further along, closer to the time when the sutures are going to come out or have come out, you can do some desensitizing, which just means that you can rub and tap your limb. You'll feel some like little nerviness, nothing really painful or just odd feeling. But as you do that more and more, the nerviness starts to dissipate and it becomes less sensitive to pressure or stimulation, which is nice to have because you're going to be wearing a prosthetic leg, and that helps get you prepared for that, for the limb being inside the prosthetic socket. So those are also things that you can talk to your physical therapist about or prosthetist when we see you in person, and we can discuss some of those things with you. I would not underestimate the importance of the therapy you receive and taking something home with you, learning from those appointments. Don't just show up and be like, all right, do with me what you will. Go in there and be a participant in your physical therapy. So now, real quick, we'll go over the nutrition a little bit. If you're in the hospital, if you've had an amputation and it's due to vascular issues, your participation in your nutrition is going to help you. Making sure you start increasing protein. Get away from nicotine and caffeines. These are things that will restrict your blood flow, reduce the amount of caffeine you take in. Certainly not saying don't enjoy a morning cup of coffee. I'm saying maybe don't drink coffee all day long. Sodas are not good for you anyway, but the ones with caffeine, if you're drinking a lot of soda, you might want to move away from that. Some of the other activities such as smoking with nicotine, I think we all know that's best to move away from that for many reasons. But now you have another reason. It's to get good vascularity, circulation, perfusion to help heal that wound. When we come in and see you in person, we're going to bring with us some information. You're going to get a folder like this. If we work with the surgeon on a regular basis, you may already have gotten this. Inside this folder, it's got a lot of information about us and whoever's talking to you, their business card will be there. We always give our patients our cell phone numbers on a business card because things don't just occur during business hours that are very important, especially when you're new. However, we do ask that you wait till business hours to call if it's a non-urgent issue, or make sure you relay that to your patient liaison, which is Theron, and he will help guide you through that. But if it is urgent, or you find yourself going, this feels urgent, but I'm not sure, if that thought runs through your head, then go ahead and contact us. We'd rather you default to being on the safe side. We will guide you from there on the urgency, but also on whatever the concern is. If it's extremely urgent, you have your limbs bleeding or you fell and it broke, 911 is your first call for something very urgent, and then or your doctor, because if that happens and you contact us, we're going to get hold of your doctor, or we're going to ask you to get hold of your doctor or contact 911. This is not life-threatening emergencies or bleeding emergencies. This is for issues where you don't know if it's an urgent, you have a question about your care or what you should be doing, or if you're doing something right that you don't feel should wait till a Monday. Inside this, there is a QR code. It says Amputee Coalition at the top, and this is a QR code that you can scan, and it will take you to a magazine that this organization publishes that's called First Steps. The First Steps magazine is really your guide to being a new amputee for your whole first year. It's got a lot of great information in it. It's going to talk about a lot of the things that we just talked about, but it's going to be even more generalized, because not only do they not know you, but they also don't know Perry Prosthetics and how we operate. Also, inside this packet, you're going to see some QR codes to our video library, and really that has a lot of information and videos of patient success stories, what other people are doing. There's several stories of showing people when they took their first steps. Literally, they haven't even started therapy yet. They just got their prosthesis, and we have a side-to-side video of then, and usually about 6 months later. Also within that video library, you're gonna find some how-to videos. One of the how-to videos is about the Rook, that protective device that I talked about. If you have that protective device, it's probably got a QR code on it as a sticker, but if not, you'll find it in that library. But the shrinker sock, how to don and to doff the shrinker sock and care for the shrinker sock, also has a series of QR codes that you can use, whether you're using the Compresso light compression or regular shrinker sock or different level of amputees. They're in there for you to use. It's on this sheet, but it's also in the video library. One last thing that I'll let you know is that we provide monthly Empower Hour events for amputees that involve other amputees. They could be simple as going bowling and having some food and just enjoying each other's company. Sometimes they're held at some of these different rehab facilities around the area, and they involve mobility and exercise and different types of treatments that you can do to improve where you are now and get to that next step as far as mobility goes. These are going to be in this packet as well. It has the different dates throughout the year and location. Most of the people that participate in them already have a device, but they're open to anybody, and many times we've had people come that are early amputees that do not even have a device yet, but they want to see what other people are doing and be able to talk to other people. And I would highly recommend it for that benefit of that alone.
You really need moral support, you need physical help, you need all kind of people to talk to. When you're an amputee, you never know anybody that's had this before, and you think you're the only one. So it's important that you can share experiences so people know that you're here. When you go to places like Empower Hour, where you had a lot of people, they're surprised to see you and want to know what happened to you, and you need all the support that you can get.
There's just so many blessings if you look for them. And there's also so many bad things if you look for them. So it's just really where you put your focus and where you put your faith and where you put your vision and what you want your future to look like.
Don't give up. It's not over. Keep fighting. You still got a lot in you.
Sometimes you physically will be there, but you emotionally won't. Sometimes your spirit's really good, but your body's hurting too much to do it. I'm always having to be reminded by Stephanie, like, I need to give myself some grace. That's okay. And try to push if you can, and try to be around people who aren't hard on you, but try to find someone that says, like, yeah, I know you're really down about this, but that's not what we have time for right now. Right now we have time for walking. And so I think that's the most important thing, is find people who push you, but push you with love, not with shame or anything like that.
We want to welcome you to be part of our family. We are here to work hard to meet and exceed all of your expectations. Thank you.